Hello everyone, myself Sanket Sanjay Kinikar here to present a short and concise seminar on the topic antihypertensive drugs. So let's have an overview of what we are going to see. The topics we are going to see are diuretics, angiotensin converting enzyme, that's ACE inhibitor, angiotensin receptor blockers, calcium channel blockers, beta adrenergic drugs, and alpha adrenergic drugs. So let's start with this session. The first, antihypertensive drugs. What are antihypertensive drugs? They are the drugs used to lower BP in hypertension. Here I have presented a classification of the antihypertensive drugs. Here we can see that they are classified into 6: diuretics, renin-angiotensin system inhibitors, sympathetic inhibitors, calcium channel blockers, and vasodilators. In diuretics, it can be classified into thiazides, high-ceiling diuretics, and aldosterone antagonists. In renin-angiotensin system inhibitors, we can classify as ACE inhibitors, angiotensin receptor blockers, direct renin inhibitor. Sympathetic inhibitors can be classified as beta adrenergic blockers, alpha plus beta adrenergic blockers, alpha adrenergic blockers, and central sympatholytics. In calcium channel blockers, we can divide into phenylalkylamine, benzothiazepine, and dihydropyridine. Vasodilators, it can be classified as arteriolar dilator, arteriolar plus vasodilator. Now, let's see the first class of antihypertensive drugs, that's diuretics. Diuretics have been the standard antihypertensive drugs over the past nearly 5 decades, though they do not lower BP in normotensives. Diuretics are classified as thiazides, high-ceiling diuretics, aldosterone antagonists. So, let's see the first one, that's thiazides. Hydrochlorothiazide and chlorothalidone are the diuretic of choice for uncomplicated hypertension, have similar efficacy and are dose equivalent. High-ceiling diuretics. Furosemide is a strong diuretic but a weaker antihypertensive than the thiazides. The fall in BP is entirely dependent on reduction in plasma volume and cardiac output. Aldosterone antagonists. Spironolactone and eplerenone themselves lower BP slightly. Used in conjunction with a thiazide diuretic, they prevent potassium loss and augment the antihypertensive action. The second class of antihypertensive drugs are angiotensin converting enzyme, that also called as ACE inhibitors. The ACE inhibitors are one of the first choice drugs in all grades of essential as well as renovascular hypertension, except those with bilateral renal artery stenosis. Most patients require relatively lower doses, enalapril 2.5 to 10 mg per day or equivalent, which are well tolerated. So now we will see the pharmacokinetics of ACE inhibitors. About 70% of orally administered captopril is absorbed. Presence of food in stomach reduces its bioavailability. Penetration in brain is poor. Plasma T-half is 2 hours, but actions last for 6 to 12 hours. What are the adverse effects? Let's see. Hypotension, hypokalemia, cough, rashes, dysgeusia, headache, granulocytopenia, proteinuria, and acute renal failure. What are the uses? It's used in hypertension, CHF, myocardial infarction, scleroderma crisis, prophylaxis in high cardiovascular risk subjects, and diabetic nephropathy. The third class of antihypertensive drugs are angiotensin antagonists or angiotensin receptor blockers. Over the past 25 years, several non-peptide orally active AT1 receptor blockers, that's ARBs, have been developed as alternatives to ACE inhibitors. These include losartan, candesartan, valsartan, olmesartan, telmisartan, irbesartan. Now let's see the pharmacokinetics. Oral absorption of losartan is not affected by food, but bioavailability is only 33% due to first pass metabolism. It is partially carboxylated in liver to an active metabolite, which is a 10 to 30 times more potent non-competitive AT1 receptor antagonist. Uses of ARBs. They are used in hypertension, CHF, myocardial infarction, diabetic nephropathy. Key point: as antihypertensive, use of ARBs has outstripped that of ACE inhibitors. The NICE guidelines considers ARBs to be preferred over ACE inhibitors for black races. The fourth category is calcium channel blockers. Calcium channel blockers are another class of first-line antihypertensive drugs. They lower BP by decreasing peripheral resistance without compromising cardiac output. Despite vasodilation, fluid retention is insignificant. Now let's see the pharmacokinetics. All CCBs are well absorbed orally, peak occurring at 1 to 3 hours, except amlodipine 6 to 9 hours. But the oral bioavailability is incomplete with marked inter and intra-individual variations. This is due to high first pass metabolism. What are the advantages of CCB? Let's see. They do not compromise hemodynamics, no impairment in physical work capacity, do not affect male sexual function, shown to have no or minimal effect on quality of life. What are the uses of CCBs? They are used in angina pectoris, cardiac arrhythmias, hypertension, hypertrophic cardiomyopathy. The fifth class is of beta-adrenergic blockers. They are mild antihypertensives, do not significantly lower BP in normotensives. When used alone, they suffice in 30 to 40% patients, mostly stage 1 cases. Additional BP lowering may be obtained when combined with other drugs. Now let's see the pharmacokinetics. Propranolol is well absorbed after oral administration, but has low bioavailability due to first pass metabolism in liver. Oral is to parenteral dose ratio of 40:1 is found. Pharmacological actions. The actions are on CVS, respiratory tract, uterus, CNS, local anesthetic, skeletal muscle. What are the uses? Let's see. Hypertension, angina pectoris, anxiety and myocardial infarction. CHF, migraine. Key points. Blockers and ACE inhibitors are the most effective drugs for preventing sudden cardiac death in post-infarction patients. The sixth and the last category is of the alpha-adrenergic blockers. These drugs inhibit adrenergic responses mediated through the alpha-adrenergic receptors without affecting those mediated through beta receptors. Renal blood flow and GFR are maintained, but fluid retention may attend fall in BP. Cardiovascular reflexes are not appreciably impaired during chronic therapy, but postural hypotension and fainting may occur in the beginning, called first dose effect, and with dose increments. General effects of alpha-adrenergic blockers: reflex tachycardia, nasal stiffness, intestinal motility is increased. What are the drugs of alpha-adrenergic blockers? Phenoxybenzamine, phentolamine, prazosin, terazosin. Uses of alpha blockers: pheochromocytoma, hypertension, benign hypertrophy of prostate. Now, this was the session. Now here we have completed. Now let's have some MCQs over the topic. The first, furosemide is preferred over hydrochlorothiazide when hypertension is accompanied by. Options are acute bronchial asthma, acute gout, diabetes mellitus, acute congestive cardiac failure. You can note down the questions and the answers will be declared later. The second question, potassium sparing diuretics is. Options are furosemide, amiloride, mannitol, hydrochlorothiazide. Third question, all the following calcium channel blockers cause tachycardia except. Options are verapamil, felodipine, nifedipine, amlodipine. The fourth question, thiazide causes all except hyperglycemia, increased calcium excretion, increased blood uric acid level, hyperlipidemia. Fifth question, which of the following diuretics is contraindicated in the presence of congestive heart failure? Options are furosemide, hydrochlorothiazide, mannitol, spironolactone. So let's see the answers. The first question, it's D, acute congestive heart failure. Second question, it's B, amiloride. Third question, it's A, verapamil. Fourth question, it's B, increased calcium excretion. Fifth, It's C, mannitol. Thank you all for this session.